Broadcasting from the historic Hebron Building in downtown Louisville, it's time for Single Payer Radio, a project of Kentuckians for Single Payer Healthcare. We are an affiliate of the Kentucky chapter of Physicians for a National Health Program. We believe a national, publicly funded, nonprofit single payer system is the solution to the current dysfunctional system that values profit and stockholder returns over patients. The views and opinions expressed here on Single Payer Radio are those of the speakers and not the station. I'm Mark McKinley, a volunteer with the group. Single Payer Radio can be heard on WFMP 106.5 on Mondays at 2 p.m., Tuesdays at 7 a.m., and Wednesdays at 11 a.m. If you can't pick up our signal in your neighborhood, no problem. You can live stream us at forwardradio.org. And if you miss a show or want to re-listen, then you can go to our archives at forwardradio.org. And briefly, thanks to Gillian over at Healthcare Now podcast team. We have permission to broadcast their recent episode with activist author Suzanne Gordon. We've had Suzanne here on the show a couple times. She's talked about the VA healthcare system and nursing in the U.S. health system. Healthcare Now is sponsoring an online Medicare for All strategy conference, April the 2nd and 3rd. For more info, you can go to healthcare-now.org. You can register at the Healthcare Now website. Check it out. Mike?
Yeah, this is Michael Flynn. Let me begin with the usual disclaimer that any comments that I make during this program represent my personal views and do not represent the views of the University of Louisville or Department of Surgery.
I'm Eugene Shively, a retired surgeon from Campbellsville, Kentucky. My views are those of mine only. I do not represent Taylor Regional Hospital nor the University of Louisville Department of Surgery.
Well, our topic for today is something that's a huge problem for this country, the opioid crisis and opioid addiction. We have a special guest today, Pat Murphy. Pat runs the Murphy Pain Center in New Albany. He graduated from U of L Medical School, spent some time as a Navy flight surgeon, did an anesthesia residency at a U of L pain medicine fellowship at the Mayo Clinic, has a master's in medical management from University of South Carolina, California, Marshall School of Business. Pat, thank you for joining us. We appreciate your willingness to come on and talk about this issue. As we have done with guests in the past, we're going to give you an opportunity to make whatever comments you want to make on this topic for as long as you want to make them. And when you're done, we'll begin the conversation. So the floor is yours.
Okay, well, thank you so much for inviting me. This is an issue that is on everyone's mind these days. And I'm just pleased to be here. I do want to, if I may, let the listeners know that in addition to being a pain specialist and an anesthesiologist, I am also an addiction medicine specialist, and I treat addiction. I am involved in some organizations, and I don't speak for them today. I'm speaking only for myself, so that's my disclaimer. But I am currently the president of the Kentucky Society of Addiction Medicine, which represents the doctors and that treat addiction in the state of Kentucky. I am also active with the American Society of Addiction Medicine, and I'm the representative on the American Medical Association's Substance Use and Pain Care Task Force from the American Society of Addiction Medicine. And finally, I'm also I'm a Gradus professor at University of Louisville, proudly a professor at University of Louisville. I am also on the board of the Kentucky Harm Reduction Coalition. So that's a little bit of my background as well. Most of what I do is pain management, but a large part of my passion of what's important to me, and actually a part of my practice, is actually treating addiction. And I am not a psychiatrist, as my background would be testimony to. I'm a medicine doctor. I do treatments that we call evidence-based, that are things like, you may have heard of them, Suboxone or buprenorphine to treat opioid use disorder, things of that nature. I tend to refer people out for counseling and things of that nature to treat addiction as well. But a lot of what I'm going to talk about today, from my perspective, is some of the science behind addiction, so that your listeners can understand that addiction is really not a moral issue. People look at it that way. People that have addiction do things that we would consider immoral. But what it is it's a disease, and there's actually it's a treatable disease. There are medications and treatments that actually work to treat addiction. So if you can view addiction as being, in that context, more of a disease process with treatment, then it takes some of the stigma away, and then you can start having ways to combat this crisis. So it is indeed a crisis, and we have gone through, obviously, the COVID-19 catastrophe, and it's still going on, and we're kind of hopefully getting near some of the end of that. But what has been parallel to this coronavirus crisis, and actually worsened as a result of this, is the opioid and overdose crisis we have in this country. It's almost been like a perfect storm. It's worsened it, and that is not going away. We see the numbers from COVID-19 dropping down. We're all happy about that. Unfortunately, the numbers from addiction are going in the opposite direction. It's like the coronavirus, the COVID-19 crisis, kindled this opioid crisis that we have, this overdose crisis, this addiction crisis, and it's made it worse than ever. It's just to give us a sobering statistic. In the last 12 months, where they measured this, more than 100,000 Americans died from drug overdoses. And that's the most that has ever been recorded in a single year in this country. And that's according to the Centers for Disease Control and Prevention, CDC. So it's more than it's ever been. We had a couple years a while back from maybe trending down a little bit, making some headway, but in the tail end, in the aftermath of this COVID crisis, it is worse than it's ever been. And that's all across the country. And it's certainly the same in Kentucky. In Kentucky, we've had the most deaths ever recorded. And it's staggering. The number of deaths were up almost 30% from the prior year. A 30% increase, despite all that we're doing, that you hear about that we're doing to combat this crisis. It was up 30%. Now that's nearly 3 times that of traffic deaths, and that's twice that of gun deaths during the same period. I mean, this is a huge problem that is getting worse, unfortunately. Most of the deaths were actually due to opioids, and really more than half of them were as a result of fentanyl. Fentanyl is a extremely powerful narcotic opioid, most often added illegally to drugs to enhance their potency. It's an opioid. It is causing people to overdose and die in staggering numbers. So we have an issue here. We have a tremendous problem. There is some hope, though, and that's really what I want to get to today, is how do we get out of this? What do we do? And it really boils down to 3 things. And it sounds like kind of the way we approach the COVID crisis as well. We have to focus on prevention. We have to focus on treatment, and then focus on the concept of harm reduction. And I'm going to explain that later because harm reduction is a very important component of this. And with that, I know you have some questions for me, and I can get into those topics as well. But maybe this is a good point to stop and open it back up to you guys.
That's great. I'm going to let Gene fire the first round across your bow.
Well, I've been interested in how we got into this problem. I've been practicing for 44 years in Campbellsville, and I remember in the 80s and 90s, we had a few addicts and more alcoholics, but why did suddenly the number of addicts dramatically increase?
Okay, that's the part of the problem is that the supply of what people were using just ballooned, and people in human nature is that people will tend to use drugs that's available to them. I mean, if there was no alcohol at all, we wouldn't have alcoholism, but people will use what's available to them. So what happened is around the 80s and into the 90s, late 90s, there was a big push by the government. There was a push by the healthcare organizations and also drug companies that were making opioids to aggressively treat pain, because we had a chronic pain crisis in this country as well, which, by the way, we still do. People are living longer with diseases and with injuries, and that could be for another topic. But what happened was we have millions of people that have chronic pain, and the thought was amongst experts in this field that you could treat people with opioids, which we talk them as narcotics, but medically they're opioids. They're drugs that are really kind of related to opium, related to morphine. So they're opioids. So people would be treated with these drugs, and they would, if they have legitimate pain, they wouldn't become addicted. And we were treating them with very high doses, and a lot of patients did well. But there is a percentage of people that are predisposed to becoming addicted to substances, and certainly opioids would be one of them. And so when they were exposed to this, and so many patients were getting these medications, that a number of them became addicted to it. Also, once their pain was treated, they kept getting the medications and were diverting them into the community. So people who were not having pain were getting access to these pills on the street. So what happened was, with that over prescribing happened, then we kind of realized, and I say we, everybody, the medical profession as well, those of us who prescribe, we realized that maybe we've been too generous with these medicines. So new regulations came out, guidelines, and so we were prescribing less of this. However, the fires had already been stoked. So people were finding that there was a need, there was a desire for opioids on the street. And so when the number of pills went down, and prescribing has gone down quite a bit in the last decade, it's gone down quite a bit. However, the overdoses have gone up 300%. Why is that? Because even though the number of pills have gone down, there's been an influx of illegal medicines and illegal drugs to fill that gap. And think about it. I mean, you can kind of control how much doctors prescribe. I mean, you can give guidelines and say we're going to prescribe less, but you can't really control. I mean, you try what comes across our borders. You can't control what's on the street. And so this unending sort of supply of illicit drugs has gone on over the past decade. And that is really fueling what's going on now, this opioid, this addiction crisis that we have, because there's just so much of it out there. So that's kind of how it got started in a nutshell. That's kind of where we are now. And it gives us an idea of how maybe we got to combat this. I do want to take a moment here and explain what addiction is. So we were talking about the same thing. Addiction is a disease, and I'm now paraphrasing what the American Society of Addiction Medicine, that's their diagnosis of addiction. So they're the experts in this. So addiction is it's a first of all, it's a treatable. It's a chronic medical disease. Notice the word medical disease, involving complex interactions in the brain. Also, genetics are involved. The environment a patient lives in is involved, and an individual's life experiences. So basically, addiction is a brain disorder. What happens is there is a part of the brain that subconsciously tells us to look for things that are pleasing, or things that it's called the reward system in the brain. And think about it: when you're hungry and you take a bite of something delicious, and you have this pleasurable feeling, that's going on in the reward center of the brain. It helps people, it helps humans find love, find shelter, find warmth, find food, find things that are pleasing to them. It's a positive thing. What happens, however, in addiction is that the stimulus to that area is so intense, it damages that circuit in the brain, and then it becomes to where there is always a deficit. There's always lack of the chemicals that are necessary to fill that void. I've heard one parent that lost a child describe it as it's a hole in your soul, and it feels that way. That part of the brain also allows people to have what we self-worth, to feel loved, to feel good about themselves. So with that area of the brain damaged, without something to fill that void, they don't just have an absence of being high. They feel horrible. They feel terrible, physically, emotionally, and even on a deep subconscious level. They feel worthless as a human, and they're going to have to find some way to fill that void, or otherwise it's just overwhelmingly miserable. So that's part of what fuels that behavior. And if you understand what's going on in the brain, then you can direct therapies to treat that. And some of them are psychological therapy, some of it's counseling, things of that nature, 12-step programs. I call it, you can almost love your way out of this somehow. But some people need more than that. A lot of people need actual medications that kind of hit those receptors in the brain that kind of fill that void. Think about somebody with diabetes. Some people can treat their diabetes with losing weight, watching their diet, exercising. They're pre-diabetic, and they do okay, but they're still on the verge of diabetes. But they got to watch things. Some people have disorders of their pancreas, or they don't even create insulin, and they're never going to have normal blood sugars. They're never going to be healthy unless they get insulin, and they get the injections. Some of them get pills. Some of them get these infusions that they wear on their belts that give them insulin, around the clock, and they can lead normal lives. They can be active and do, and be as active as anybody else. But then when they don't have the insulin, however, then the harmful consequences of diabetes come up. That's kind of the way addiction is in a lot of people. Because of that brain issue, if they don't have treatment that's covering that area of their brain, they'll have the consequences in addiction, however, are not so much low blood sugars, high blood pressure, things like that. It's these feelings we talked about, these emotions, these deep, that hole in the soul. So we have to find ways of healing that. So it is the first thing that the American Society of Addiction Medicine says is it's a treatable chronic medical condition. So any listeners out there that think they're struggling with addiction, I want you to know that the definition of addiction is that it is, first of all, it's treatable, and it's chronic. It's a medical disease. It is not a moral failing. And so with that being said, I guess hopefully I've answered your question. But I think I've got off track there. But I want to make that point very, very clear early on in this.
Pat, let's take this. I don't know if a step forward or a step back. Who? And I don't know if you can answer this, but who are the addicts? Are they young? Are they old? White, black, brown? And then after you've answered that question, if you could then move on to kind of a second part and indicate what are the sort of predicting factors, if the predisposing factors to whoever the other demographic of the addict.
Okay. Well, first of all, I'd like to, if I may, I want to get away. Language is important, and I think that in this field, especially, there's been a lot of hurtful language. You know, you talk about people being junkies or whatever, things of that nature. But these are patients. These are people. These are our friends, our neighbors, our loved ones, our sons, our daughters. These are people that have a disease. So I like to call them patients with addiction, people with addiction. Addicts is you kind of have as a negative connotation. So if I may, these people that with the disease of addiction, people with addiction, generally speaking, it seems to be a younger age group, because the developing brain is very sensitive to these stimuli, these medications, these opioids, alcohol, methamphetamine, things of that nature, cocaine, things that would be stimulating to the brain in this area. Young people are very sensitive to that because their brain's developing. So that's why we really need to do our best to encourage young people to not experiment, not use these medications despite peer pressure or whatnot. But it can hit anybody from any age, but it tends to be younger people in their 50s and younger that are really struggling with this. But it can surely hit any age. It from the standpoint of race or economic numbers or whatever, it's those are factors involved, and addiction does disproportionately affect people of color and people that are traditionally marginalized communities. A director of the National Institute of Drug Addiction, Director Nora Volkow, she has a quote that I want to give you here. She said, systemic racism fuels the opioid crisis, just as it contributes mightily to other areas of health disparities and inequity, especially for Black people. And so, they in areas where there's not enough services, it's going to be a problem because the treatment's a big part of this. In fact, between 2002 and 2010, last decade, and even continuing today, there's been a decline in the number of both public and private nonprofit outpatient substance use disorder facilities. And there's been the drop in the number of treatment facilities has been felt most acutely in areas where there are a high percentage of Black residents, for example. They are disproportionately burdened by this decline in public facilities. So we really need to focus on those factors to treat this problem as well. But anybody, nobody's immune from this disease. And I can say this, that there are some factors that we look at it to, predict what, might make you more prone to it. There are, factors that are involved the person. There are factors that involve the environment, and there are factors that involve the actual substance. So let's talk about the person first. So, everyone has their unique biology, and you also have your genes. And believe it or not, genetics, are a big part of this. And some people have estimated that as much as 40 to 60% of the risk is contributed to by your genes, your family. So, and that doesn't mean like your distant family, but people that have personal relatives, that means your father, your mother, sister, brother, even your child. If they have a problem with addiction, then you might be at risk for addiction as well. So it does run in families. So keep that in mind. There's a high genetic component to it. As I mentioned earlier, the age at which you start using drugs is important. Younger people, their brains are developing. So the keeping people that are young and with the developing brains off these drugs is very important. Some people are very sensitive to the drugs too. So, I mean, some people can drink alcohol and say, I don't feel a thing. Others can, they get intoxicated very easily. So depending upon how a drug affects you, I've had some people that take, patients of mine that take a pain medicine after a surgery, for example, and say, well, I don't feel anything with it. Matter of fact, it makes me kind of sick. Others will say, Dr. Murphy, I liked that medicine too much. I'll say, yeah, you probably are genetically predisposed to liking that medicine. So we're not going to use that one anymore on you. Consider yourself kind of allergic to that. For example, if it's Percocet and you like it too much, yeah, I actually, my pain got better, but I also felt really good and energetic. Okay, maybe you shouldn't be taking Percocet then, because maybe you are going to be more sensitive to that, the bad effects of that medicine. Also, people that with certain mental illnesses, such as depression, anxiety, ADD, and they are more likely to maybe use other opioids and medications for non-medical purposes, and that can also predispose them. Interesting enough, used to be kind of a gender gap here where the men were more likely to become addicted to drugs than women, but I guess in the name of equality, the women are closing that gap now. So I don't think that it's a major difference between men and women in this. There is some difference as well. Ethnicity is a factor, and some people genetically, because of their ethnic background, are more sensitive to medicines. They don't have the enzyme to digest alcohol as easily as another ethnicity might. It tends to run in that way. But and it's also societal factors about where people are placed in society and where they live, and so there are some ethnicity factors. Environmentally, where they live, where you live, who you hang out with. I know Alcoholics Anonymous has a great statement that's a saying that's been around for a long time, and they say, avoid triggers of persons, places, and things that trigger you to want to use again. And it's true. I mean, if people in your family around you, your peers are using, that's a risk factor. Also, the availability. I mentioned that earlier. If there's a lot of the drug around you and it's easily available to you, then that's a risk factor. And this is something to keep in mind. Social stressors. We're going through a lot right now with, and we just went through a lot with the COVID crisis. We're still going through it, but now people are worried about Ukraine and World War III and everything, and the gas prices and inflation and jobs. All this stuff is just causing stress, and social stress leads people to look for other outlets to deal with that. One of which could be using drugs, and that's a risk factor. So those are some of the things that we can look to. And if you think about all those risk factors, you can look at ways of prevention as well. When you think about those things, a lot of it just has people need to just be aware that, because of these risk factors, and I mentioned genetics is a big one. Try to avoid exposing yourself to the environments, to the persons, places, and things that might lead you down that pathway.
As a surgeon, how can we recognize a person who's may have a genetic defect or more susceptible to drugs? And how should we change the medication that we give them post-op to try to prevent that person from getting addicted to drugs in the post-op period?
Well, I think the first thing to do is to be aware that it's an issue. And also be aware that people have pain and they deserve to be treated for their pain, and they need to be treated for their pain. Otherwise, they're going to have disability and bad outcomes as well. So in no way am I saying that we should not aggressively treat pain. But some pain, from surgeries respond very well to anti-inflammatory medicines. Others don't respond so well. I mean, anytime there's a cut on you or surgery, there's going to be some inflammation. So to a degree, anti-inflammatories will work, but they also can increase bleeding. So you got to balance it, the pros and cons of the anti-inflammatories. But when you can use other measures besides opioids, maybe the anesthesiologist can give a nerve block, so to numb the extremity for a while. Some topical agents. There's things called TENS units, which kind of stimulate on the skin that kind of blocks some pain. But just being aware to look at the other options, and not just as a knee-jerk reaction, say, well, I'm going to give you my usual dose of 7 days or 14 days of Percocet, for example. So think about that, but also realize that we do need to treat their pain. In Kentucky, there's been a law passed recently that says that for the most part, for the first prescription, it should be 3 days. And I think that the CDC guidelines kind of talked about 3 to 7 days as being the window for a first prescription. Most people can get by on less medicine than we had been prescribing in the past. But what you do is you can give them a smaller amount and then be available to them in a few days and say, do you need more? How are you doing? And also, aside from that, just asking the questions, screening patients, and really the first thing that we need to ask is just, frankly, have you ever had a problem with drugs or alcohol? And oftentimes they'll tell their doctor, they'll tell them in confidence. And that's important to know, because if they've had a personal issue with it in the past, they're probably at high risk for having an issue in the future. And then the next question is, has any of your close relatives had a problem with drugs or alcohol? So just those two questions by themselves, will be a good screening test. You ask them, in the last year, have you had a problem with drugs or alcohol in the last year? And they might tell you that as well. So, just being aware and asking the questions, giving them less, using other modalities as you can to treat their pain, but maybe not with the higher amounts that we were used to giving in the past. And then also telling people, I think in Kentucky it does. And by the way, the regulation in Kentucky, to my knowledge, does not apply to surgery. You are, as a surgeon, able to give 2 weeks of the medication without much of an issue. So for surgeries, it's 2 weeks. For most everything else, it's they want you to do 3 days initially, unless you can justify in the record why you're giving more. So
Pat, give us a kind of a listener-friendly overview of the treatment process for opioid addiction. I'm assuming there are different levels and grades of it, but just so that the listeners get a sense of what's the process and how do you what are the different options or the different methods that you can use to treat somebody who you would identify or diagnose with this condition?
certainly, the most people don't get treatment. In fact, statistically, about 1 in 10 people with a substance use disorder receive any type of specialty treatment. So there is a real lack of treatment out there.
Now, is that an issue of our healthcare system, or is that an issue that these people haven't sought treatment?
It is both, but it certainly is an issue of our healthcare system.
Yeah.
2/3 of the people that need treatment don't have insurance or don't have access to it because of insurance. And insurance, lack of insurance, has been cited in studies as the number one reason why people do not follow through with treatment. So, it's a huge issue. The availability of treatment, the availability of treatment is one thing. We need more people we need more facilities. We need more people to treat this crisis. We need to deal with it like it's like we're dealing with COVID as a huge crisis. We need more people treating it. We also need people to have access to it, and they don't have access. The medications are expensive. They can't afford Suboxone, for example. It's difficult. Methadone clinics are really hard to get into sometimes, and they are expensive. Insurance may not cover them. Also, people may not want to. They're private about it. They don't want to let their insurance company know or let anybody know they're getting treatment for this because of the shame and stigma. That's a barrier that we have to get over as well. So so the insurance is an issue. The availability is a big issue in terms of people getting treatment.
So tell us about the process, though.
Okay, well, there's no one size fits all, and it really should be individualized. But a lot of people, it starts with somebody being ready for treatment, and they're ready, and it's somebody hit rock bottom or whatever. That we've heard that term before, but there's what's called a readiness to change. Somebody is open, and when you as a clinician or as a doctor or a family member, when you seize that moment, when your loved one or even you, when you have that moment where clarity, where the disease process is allowing you to think clearly just for a moment, and you realize, I have got to do something. I've got to change something here. That moment of clarity is a golden moment, and it must be acted upon. That's when somebody's open to getting treatment, and you can get them places and work with them however you can. Most of the treatment is therapy. Might be community-based, like a 12-step program or a peer group or something of that nature, or even with your church, things, the people that are working with you, trying to, get you to have a way to change that destructive behavior. And, but a lot of people need to have detoxification. They need to get the medicine, the drugs out of their system. Now, you can be treated, even when you're using, you can be treated. In fact, there's a concept of what's called harm reduction, where the idea is to think about like clean needle exchange and giving people Narcan so they don't overdose and die if you can avoid that, from the opioids. You're not supporting addiction by doing that. What you're doing is keeping people alive until they are ready, till they have that moment of clarity where the disease lets them seek out treatment. And people that are involved in harm reduction, like the clean needle exchange and the Narcan distributions, they are many times more likely to go into treatment than somebody who is not in a harm reduction program. So keep that in mind when we're talking about the importance of harm reduction. But I think if you look at a pyramid, the big base of the pyramid is psychotherapy, counseling, 12-step programs, and then there's the detoxification facilities where you go in and you get off the drugs. I got to tell you, that's important, because you can't do therapy, psychotherapy, until you have the drugs out of your system. I mean, it's really not as effective. You can do it, but it's really most effective when you're thinking more clearly, and that detoxification has to occur. But that does not mean your addiction, your disease is treated. It just means the drug is out of your system. So you get the drug out of your system, then you follow through with the treatment. And then treatments consist of like I said, mostly psychotherapy, but we have treatments for opioid use disorder. We have treatments, and there's the main ones are the buprenorphine, which is Suboxone. You've heard of Suboxone before. Methadone, and there are methadone clinics where people can get that. And then the third thing is that naltrexone, which is basically the antidote to opioids, and that's usually an injection. It lasts usually once a month, something of that nature. Now, you can't get the injection for the naltrexone unless you have been detoxified, unless the opioid is out of your system. Because if opioid's in your system while you're getting the naltrexone, it will put you into withdrawal. So that's the one thing. The naltrexone has had some success in keeping people who are off the opioids, keeping them off the opioids. But I can tell you that the naltrexone is so much less effective in keeping people in treatment than the buprenorphine, which is Suboxone, and the methadone. The buprenorphine, the Suboxone, and the methadone have long track records, lots of evidence to show they are very effective in helping people stay in treatment and stay alive and live with this disease process and actually treat it. We call that these evidence-based treatments. So if there's one message that I want to get out there as well, that using methadone or using Suboxone or buprenorphine is not replacing one addiction for another. I've heard this in self-help groups and people that I've, places where I've been. The worry is that, well, you're addicted to heroin, so you're just making yourself addicted to Suboxone, and that is so not the case. What you're doing with Suboxone is you're treating those receptors in that part of the brain and calming them down. It is a medical treatment. It is not being addicted to another drug. In fact, people that take Suboxone for their treatment, you don't get high off the Suboxone. What it does is it might bring you back to where you feel like a more normal person, but there's really no high in most people with Suboxone or with buprenorphine. That's not to say you can't get a problem with it, and people can abuse those drugs. But honestly, most of the Suboxone that is diverted or on the street is not used by people to get high. It's used by people to self-treat their own addiction because they can't get it from someplace else, or they're afraid to it. There's a stigma to it. But the Suboxone treatments, which can be done by any doctor who has a DEA license and has a little extra training that they can get online, and then you can get like a little, it's called a waiver from DEA. So any prescriber with a DEA license can get that training and prescribe Suboxone out of their office. Now, methadone right now has to be done with at a methadone clinic. That's really restricted by the U.S. government. There are regulations for that. There's a bill before Congress now that is going to try to open that up to where certain physicians that have especially training can treat with methadone for addiction out of their offices, which would open up again more services for people. But Suboxone, buprenorphine should be available everywhere. It should be very, very common. Unfortunately, most doctors that have that waiver do not treat to their limit, because there's kind of, the government kind of gives them a limit to what they can treat, but they're way below their limit, or they don't do it at all. And the number of doctors with DEA licenses who actually get this training and do it is extremely low. So that's where we could make, so if there's any physicians out there listening to this, that's where we can make a huge impact. If everybody would just look into this, realize that it's a huge crisis, and they can help out by just treating 5 or 10 people in their practice. If everyone did that, we would really make a big dent in this. COVID crisis came. I mean, I had some time on my hands because I had to go telemedicine, and I kept my practice wasn't as busy because of we shut it down basically. So what I had time. So like a lot of people, I went down to the Kentucky Fair Exposition Center and the Broadbent Arena. I volunteered and I gave out some shots, and I helped out with as a doctor. I'm not an epidemiologist, but I can give shots, and so I helped out at Broadbent Arena. But if every physician that had a DEA license said, I'm going to read a little more about this because it is a huge issue. I think I'm going to treat maybe 5 or 10 patients. I'm going to take a few people on. I tell you what, as somebody who just, I didn't start out in medical school wanting to become an addiction specialist. I just found out that it was necessary and important. And once I became certified in anesthesiology, I finished the Navy, I finished my pain fellowship, I was an anesthesiologist, and it just was obvious that there's a need for this. And it was so necessary. And I tell you what, as a physician, it is incredibly gratifying. It is one of the most gratifying things. Everything I do is I think I enjoy, and I'm privileged to be a physician. But one of the most gratifying things that I do is to give people treatment for their addiction, their opioid use disorder, and allow them, with very little effort on my part, honestly, to lead more normal lives. It's just very necessary. So if there's any doctors out there, or if you have patients talking to your doctors, have them look into that, because that's where we can make a big dent in this.
I have a question about Suboxone. Should you gradually reduce the dose and try to get people off Suboxone, or should you treat them with a maintenance dose over a long period of time?
Generally, when you have an opioid addiction and that part of your brain is damaged, think about how long it will take for nervous tissue to recover. Usually it's a long time, if ever. Think about people that have strokes, for example. I mean, they have those deficits in their brain. They have the stroke symptoms for the rest of their lives. Some people, they'll recover. So it's the same thing with addiction and with Suboxone. Some people will just need it as a bridge to get to their, we call it in many respects, medication assisted treatment. So they're using the Suboxone to calm everything down, to take away those cravings, those withdrawal symptoms, and then they can get into therapy, and they do okay. Some people need to stay on the Suboxone for long periods of time, and then they can get off of it. They can try to taper gradually, but there's no reason you must taper. I mean, unless I guess people just want to, and then the cost can be a problem. They lose their insurance. But think about like I said with diabetes. If you have a diabetic condition to where you're not making insulin, and then later on you say, well, I've lost weight, I've exercised now, I think I'm going to do without the insulin. Well, they're still going to die because they're not going to have insulin. They're going to have a crisis with their blood sugar, and they're going to die because they just don't have insulin. Some people's brains will always need that medication, like Suboxone. So it's individual, but we do not encourage people to aggressively try to get off of this. People in my specialty, that the American Society of Addiction Medicine, there's no push to get people, once they're stabilized on the medication, to get off of it anytime soon. But we can bring it up, and it's always on the table. And I have patients that ask me whether they want to get off of it. And I'll say, why do you want to get off of it? I had somebody the other day ask me, I just want to get off this stuff. And I said, but you're doing so well. And this is a professional doing fantastic. I'm just so tired of people just knowing that I'm on this, and they look at you terribly, and it's the stigma. And so I spent like the next 30 minutes telling this person that, you shouldn't be ashamed of this. You should be this is nothing, and this is nobody's business. This is medication treatment. I said, own it. You are doing great with this. And maybe if you go off this medication, you can destabilize and you be back to where you were. I said, but I'll work with you either way. But if we're going to do it, it's going to be extremely gradual. And I'm going to be there for you in case you feel the cravings come back. But it's not weakness on your part. It is not a problem if you want to stay on this medication. You certainly, it's very reasonable to do that. So to answer your question, it's individualized, but for most people, it is long-term.
So give us an idea, kind of an overview about how effective the treatment is for someone with an opioid problem. I had heard there was a talk from a previous health commissioner from Kentucky, which is maybe 5 or 6 years ago. And one of the things that stayed with me was they indicated that the recidivism rate for treatment was almost 70, was over 70%, which is incredible. You get treated, have an overdose, you get into treatment again, it just seemed to be this ongoing scenario. So is that something that's still true today, or just kind of, give us a sense of where the effectiveness of treatment?
Well, people that are taking these medications, they're about 50% more likely or so to stay in treatment. So if you stay in treatment, then you're likely to do better. Now, the idea that there's recidivism, or you're going to go back to using these drugs at some point and fall off the wagon, as you will. This is something we never want to have happen, but it's a natural history of this condition. I mean, it's like any other chronic disease. At some point, it could get worse. At some point, it could come back. Think about people that have cancer in remission. It might come back. People that, again, the diabetes example, at some stage in life, things could get worse, or somebody could just quit taking them, the medication, and then have some issues or problems with it. And addiction is no different than other chronic diseases. There is we call it a relapse sometimes. The possibility of a relapse is always there. It's common. It doesn't mean failure. It doesn't mean that the other treatments didn't work. It means that the disease has come back. It's gotten worse again. So the important thing is that the person with addiction has a framework and recognizes it, and their loved ones recognize this, and okay, we know what to do now. We know what worked in the past. Let's get back into treatment. Let's go back into therapy, back into treatment. Let's do these things that are going to make me well again. And it may be that there's the pain has triggered the addiction to come back. It may be like people that have chronic pain. They may have had an accident. It may be that they've lost their job, or that their bipolar disease or something of that nature has gone off the rails a little bit. There's a lot of reasons that people can, relapse in a sense, and it's not necessarily, the problem that the therapy in the past didn't work, but and these people that want to get off Suboxone, for example, they might do well for a couple of years, and then something happened. The persons, places, and things we talked about earlier can trigger something, but that's not a weakness or a failure. That's what happens in this disease. So to say that, there's a high incidence of recidivism, it doesn't mean that the therapies don't work. It means maybe that the therapies worked, something else happened. There's lots of factors involved here. We do know that there is treatment. Treatment is effective, and the key is that when somebody does relapse, we recognize that, get them back into therapies that worked for them.
Okay, we're getting close to the end here, Pat. We're, as you know, this is Single Payer Radio. The three of us are part of a group that's promoting, Medicare for all, a change in the healthcare system in this country. Can you give us a sense of how the ability of someone with this problem to get treatment would change if we had, instead of having the healthcare industry we had a single payer system, or a system like they've got in every other first world country where there's universal healthcare in Britain or in France or the Canadian, how would the ability to manage this problem be different if we had a healthcare system that was more universal? And I think we're we get to about the last 5 minutes there, 4 minutes here.
Well,
So you have to talk fast.
Okay. Well, as I said, the number one reason that people gave, and it's at least one study I just looked at, that they did not have treatment was because of insurance issues. People are ready for this. They want to check themselves into rehab, for example. They go there and they go, well,
Right, yeah.
we checked your insurance and we don't, it's not covered. So why don't you go do this or that, And that's really tragic, because again, that golden moment to help them. So if we had a system where it was not that the insurance issues was not a barrier to care, that would make a huge difference. And the medications, for example, are expensive. Suboxone is not a generic medicine, as far as I know. It's expensive. It's very effective, but it's hard to get sometimes. And I know a lot of patients that I have, they have insurance, but they have to pay cash for their Suboxone because the insurance won't cover it. So it's a private insurance issue as well. In Kentucky, we've done away with, hopefully, recently did away with requiring prior authorizations for Suboxone therapy for this type of treatment. And I don't know how that's worked out yet so far, but see, there are things that we're trying to do to improve that access. So I don't know exactly which system is the best one, but I can just tell you that whatever system that we're going toward, this is a huge crisis. It's a huge problem. We need to recognize that and remove these financial barriers to patients getting this treatment, because they are dying in the hundreds of thousands and it's not getting better.
We're going to have to leave it there, Pat. I want to thank you. This was really a great program. We've learned a lot. I think Gene wants to make one more final comment, and then Mark is going to close it out.
Very quickly,
I
Jim.
got a burning question.
Can I give a
we
phone
solve
number?
the drug addiction problem without trying to do something about the cartel in Mexico?
I'm sorry, what was the question?
Can we solve the drug addiction problem without trying to do something about the cartel in Mexico that's selling all these drugs?
Well, that's just one factor. As I said, the supply of the substances is the big thing.
I don't think we're going to be able to get into all.
No.
Okay.
Sorry.
Yeah,
Dr. Murphy.
I think we have to treat the patient first, though. It starts with the patient. Let's leave it with that. And I want to give a number here. If anybody wants help with this, call 1-800-662-HELP. 1-800-662-4357. They will get you help.
Fantastic. Dr. Murphy, thanks so much for this important information. And I hope that policymakers in Kentucky receive this message, because we can't incarcerate our way out of this problem. More New Testament, less Old Testament. For more information about the group Kentuckians for Single Payer Healthcare, you can go to kyhealthcare.org, kyhealthcare.org, and 1-800-662-HELP. Dr. Murphy, thanks so much.
Thank you. It's
Thanks
very
again,
good.
Pat. You were great.
Thank you.
Thank you. My pleasure.